Today we would like to welcome Dr. Timothy Pawlik to the Residence Corner. Dr. Pawlik is the recently appointed Chair of Surgery at The Ohio State University Wexner Medical Center and the Urban Meyer III and Shelley Meyer Chair for Cancer Research. He was previously on faculty at Johns Hopkins Hospital Department of Surgery, where he was the John L. Cameron Professor in Alimentary Tract Diseases and Chief of the Division of Surgical Oncology. Dr. Pawlik received his medical degree from Tufts University School of Medicine, where he also received his MPH. He completed his surgical training at the University of Michigan Hospital and spent 2 years at Massachusetts General Hospital as a surgical oncology research fellow. He completed advanced training in surgical oncology at the University of Texas MD Anderson Cancer Center. Dr. Pawlik also completed a fellowship in medical ethics at the Harvard School of Public Health, as well as a Master in Theological Studies degree from Harvard Divinity School. In addition, he was a National Institutes of Health KL2 clinical scholar and received a PhD from the Johns Hopkins Bloomberg School of Public Health in clinical investigations. The author of more than 600 published articles and more than 50 book chapters, Dr. Pawlik has also edited 5 surgical textbooks. He has served on the executive councils of several premier national surgical associations and is the immediate past president of the Association for Academic Surgery. Dr. Pawlik's primary clinical interests include alimentary tract surgery, with a special interest in hepatic, pancreatic, and biliary diseases. We are honored to have the opportunity to speak with him today.
Thank you for joining us today. I wanted to ask you a couple questions. The first is, what did you find the most challenging about transitioning from the role of a trainee to a practicing surgeon, and what choices did you make that you think helped foster your academic success?
Well, I think the transition from a trainee to a young academic surgeon is really an exciting time in one's professional career. There can be some challenges, and I think those largely revolve around time management and trying to juggle a lot of different balls. Especially if one aspires to be an academic surgeon, it can be challenging trying to build your clinical practice as a young faculty member, and at the same time trying to launch your academic and research career. And so that's one of the things that I would tell young faculty members to really think about and to try to strategize how they're going to build their clinical program, how they're going to build their research program. And I guess one piece of advice I would have is that I would encourage young faculty who are starting their career to be clinically active. I think it's important to, when you graduate, be clinically active and use your skills and hone your skills. And also it's kind of fun because we trained all these years to become surgeons, so we want to be operative surgeons. I do think at the same time, starting off, really try to focus on your academic career. Because the referrals will always be there, and if anything, you will only become busier and busier clinically. And early on in your career, when you're still young, is really the time that you have to focus on your academics. So try to identify, what makes you passionate, what you may be good at, whether that be basic science, translational science, or health services research. And really try to identify an important question that you can fashion a career around and a research trajectory around, and that you can pursue that idea over multiple years and kind of build a portfolio of publications around your research question, and then also hopefully a fundable idea that perhaps you could put in for grant funding, whether it be a PCORI or the NIH or HRQ or other funding mechanisms.
Thanks. And if you had chosen a career outside medicine, what do you think you would be doing now?
I think it's hard to say what I'd be doing now. Maybe a professor of theology. I have an interest in medical ethics and moral philosophy and moral theology. I was a theology major as an undergraduate, and I went to divinity school actually during residency at the Harvard Divinity School. So I've always very much been interested in philosophy and theology and moral ethics. And if I didn't go into surgery, perhaps I would have pursued that as a career.
Well, how do you think those interests shaped your approach to medicine and surgery then?
Yeah, so I think that's a good question. I think any experience that we have colors the lenses that we see life through. And so I think part of my interest in theology and moral philosophy, I think, just kind of informs how I approach different situations and people and patients. I'm also an oncologist by training, and in the field of oncology, there's a lot of existential issues and questions that are important to patients around end of life. I think having some background in theology and in philosophy perhaps just makes me a little bit more aware of some of the other non-medical issues that some of my patients may be facing when they're confronted by these life-threatening diseases.
Sure. Well, now we're going to turn our focus a little more towards the clinical side of things. So what do you think is the most important thing that we can do as surgeons to better improve outcomes for pancreabiliary cancer patients?
So I think there's a number of things that we can do to improve outcomes for patients. And again, I would harken back to our kind of dual roles as clinicians and scientists and researchers. So I think there's a number of things that we can do within the clinical realm, and those would largely be around one, just be an excellent surgeon. I think that we want to have good technique, we want to be meticulous, we want to be scrupulous, and have good outcomes. And then the other thing I would say is that I would emphasize that in our own practice and in our practice with our partners is try to standardize what we do in the operating room, what we do outside the operating room, whether it be through care pathways, through enhanced recovery, after surgery pathways. Because I think that a lot of quality issues in surgery revolve around variation and unwanted variation. And I think the first step to improving quality is to standardize the process. Because if one standardizes the process, then one can improve the process over time because you are improving something that you have all agreed upon and is standardized. And then I think it's important to keep track of our outcomes. And all of us are doing this now at our departments and our institutions, and really on a regular basis look at our quality metrics, look how we benchmark towards other surgeons, and then see how we can not only personally improve, but how can we systematically improve as groups and institute new programs that may improve the quality of care for our patients. And I think that dovetails into the other part of it as scientists, is that we want to be studying this issue. And if we learn new ways to deliver better care with better quality outcomes, then I think it's important to write that up, to rigorously study that scientifically, and then to disseminate that information to other people at your institution and to other people at other institutions so that we can all learn from one another about what best standard practices are and how we can improve the quality of care for our patients.
What advice would you give to a young surgeon entering a new practice where some of those things may not be standard and where they want to introduce some of these enhanced recovery pathways?
So the first thing I would do, I would say, try to get some data. I mean, I think one powerful way to show your partners maybe some of the things that are going on is to present in a non-threatening way, and perhaps even in an anonymous way initially, some of the outcome data in your group or in your division. And perhaps your group would be surprised by the amount of variation that occurs, whether it be with regards to how often one surgeon transfuses compared to another surgeon, or SSI rates from one surgeon to another, utilization of labs, length of stay. And I think it can be quite eye-opening to show the amount of variation within one's group. And then once those data are on the table, one can begin to have a discussion about how can we start eliminating some of this variation, and what care pathways can we put into place, what things can we agree upon as a group, that perhaps we all should do it this way, and this may lead to better outcomes for our patients. So I think data are often very compelling, and as surgeons we're all competitive people, and everyone wants to do a good job, and we all think we're doing a good job, and sometimes we are and sometimes we're not. And I think sharing data in a non-threatening way can really help people better understand maybe some areas where they can improve.
Sure. And along the research lines, if you could direct the resources of the NIH for research in GI malignancies in any way you wished, what do you think would be your top priorities going forward?
So I'm probably not smart enough to answer that question. I think that a lot of the priorities at the NIH are probably more appropriately set by people smarter than myself. What I would say, though, is that I think that it is important that we focus not only on the underlying pathogenesis of disease and put money towards understanding disease mechanisms, but also that we focus on translational medicine, and that we want to put our money and our effort towards new novel therapeutics to help patients who have these types of cancers, and to better understand how we can individualize care for patients, and how we can tailor, whether it be surgery or chemotherapy, to patients in a very specific way, based not only on the type of cancer that they have, but based on the molecular and genetic profile of that specific cancer. And then the other thing that I think is important, whether it be at NIH or through PCORI mechanisms, but this real emphasis on patient-centeredness. And I think that's been one thing for me that's been really refreshing, is to see a real emphasis on that in a number of granting mechanisms, to focus on patient-centeredness and to really roll into our research the issue of patient engagement and shared decision-making around how we make these decisions around care. Because many of these therapeutic molecules that we have now do provide some benefit, but frequently the benefit is somewhat marginal at a very high cost to society. So I think further investigations about the relative benefit of novel therapeutic targets, and whether patients desire these and whether society can afford to pay for these, I think is an important future area of research.
Well, thank you very much for your time today, and we'll hope to hear from you some more in the future.
Thank you very much. I really appreciate this opportunity. Good luck.